As Shane mentioned, this is going to be recorded, so it'll be available to you after this presentation. If you're going to do the certificate course, there is also going to be a quiz released about an hour after this presentation for you to complete. So today, we're going to be talking about domains of medicine and data types 1. So a little bit about me if you're interested. Basically, like this slide is mostly just for my email. If you have any questions, I'm happy to answer any emails that you may have. I try to answer within 48 hours. If I don't answer within 48 hours, just send me a reminder email. No conflicts of interest to announce. And this is kind of the outline for today. So I'll start off by talking about some health data, a brief intro to specialties in medicine and the use of AI. The emphasis of this lecture, though, is going to be on primary care, public health, and emerging health apps that use AI. So I'll just get the health data stuff out of the way. This is mostly just a terminology thing. So this is a nice diagram of where health data can come from. But then in terms of data types, like sometimes you might see people using just different terminology to describe different types of data. So I just wanted to present these just to get them out of the way. So in terms of data types, you can categorize them as structured and unstructured. So structured data is considered standardized data. So some examples of structured data are things like age or gender or numerical test results. So structured data can very easily be transferred from one health information system to another. So imagine like you have like some sort of file, like let's say a .csv file. One column you have a unique de-identified patient codes, and the other column you have a date of birth. Like this is very straightforward. If you want to take it to any information system, it can very easily be decoded. Unstructured data, on the other hand, is not standardized. So it usually requires a lot of pre-processing steps if you want to transfer it to another health information system. Examples of unstructured data are things like audio recordings or emails or the charting notes in a physician's office. You can also categorize data in terms of quantitative and qualitative. So quantitative data is made up of numerical features. These are things like age, weight, body temperature. Qualitative data is made up of non-numerical features, and they're usually observational. So here's like an example. At 17:30 hours, Mr. Smith appeared agitated and expressed ideas of reference. Like this would be really hard to quantify numerically or to try to give it like a value. So there are a lot of pre-processing steps that are required if you want to put it in another health information system. In terms of data collection, you can quantify it as primary data source or secondary data source. So let's say you're part of a research team and you're interested in answering some clinical question. You have two options. Option 1 is starting from scratch, and you organize for a way to collect the data from a hospital or a clinic. Going this route gives you full control of what kind of data you're getting. You can control the quality of the data, you can customize the types of features you collect for your own study. The problem is that this can be very time and money costly, and you'll have to do a lot of paperwork related to ethics in order to actually make this happen. Option 2 is looking for a source that already has the data that you need. This can be from research groups, government or non-government organizations, and companies. This is a very quick and cheap, easy way of getting your hands on data. You would also have access to really large data sets that you otherwise wouldn't have if you were collecting the data yourself. The drawbacks of accessing secondary data is that you can only have what the data owners give you, and you could be missing out on including otherwise valuable features in your data set. Okay, so now that we've got that out of the way, I'll start off with talking a little bit about domains of medicine. And my lecture style, like I like to be pretty interactive. Like I personally can't listen to someone talk for 10 minutes straight. So for today, let's try to use a chat box to interact. So in the bottom of your screen, there should be that chat box that's open for you. And I'm going to be giving you cues, like type in whatever comes to mind. This is mostly just to keep you engaged. If you're not comfortable answering, that's okay. But there isn't going to be like a lot of like right or wrong questions in this. I'm mostly just going to be seeing what your thoughts are and what your understanding of certain things are. So I just want to test out this chat function. So we're going to play a nice friendly game of guess the medical specialty based on stereotype. Okay, so mediocre grades, pumps weight at the gym, does jujitsu, loves using power tools. Which one of these options do you think fits this medical stereotype? Okay, let's see your answers in the chat. Okay, yes, Khalid. B. This is probably orthopedic surgery. Okay, socially awkward, probably a gamer, probably paler than what they should be, drinks lots of Pepsi. Which one of these options do you think fits? Okay, so you got some B's and plastic surgery. Oh, Khalid, you're right, twice in a row. Um, Radiology. This is a radiologist for sure. Okay, last one. Pretty shallow, lengthy skincare routine, spends 30 minutes in the morning doing their hair and makeup, looks younger than they actually are. Which one of these do you think it is? Okay, getting lots of A's. Yes, this is a derm. This is a derm physician. So this is, of course, just stereotypes, not necessarily completely true. Before med school, I personally had no idea how many medical specialties existed in medicine, and there are way more than I expected. And these are some nice diagrams of how to find the medical specialty that's right for you. I especially like this one, the hot, crazy matrix, another good way of classifying medical specialties. I personally think nephrology deserves better than this, but that's okay. Okay, so as I said, the goal for today is going to be mostly talking about primary care out of all of the medical specialties. So when I talk about primary care, I'm really talking about family medicine. So family doctors are kind of like what we used to call general practitioners or GPs. Historically, doctors would complete 2 years of medical training after med school. And if they wanted to specialize in some specific field like cardiology or rheumatology, they would continue their training. The doctors who didn't want to specialize would stop their training after the 2 years and they'd be called GPs or general practitioners. So this system has since changed. And if you want to work in a clinic as a primary care physician, you'd specifically apply to the medical specialty called family medicine. So that's why I'm going to mostly be using family medicine and family doctors to refer to primary care providers. And basically, family doctors are the go-to person for any problem that's not an emergency. So any problem that doesn't threaten life, limb, or sight. So the role of primary care providers, they actually have a few. They're the first line. And this is actually a really big one. They play a really big role in preventative health. So this is like, it requires recognizing lifestyle patterns and genetic predispositions that may lead a patient to developing an otherwise preventable illness or disease. This is the most effective way of saving people, basically, is preventing the disease before it starts. You also have screening. So screening for certain common diseases is also a big part of primary care. I'll talk a little bit more about this later. Of course, diagnosis and referral to specialists. If someone comes in for a specific problem, the family doctor will try to make a diagnosis and come up with a management plan, or refer to the patient to a specialist who's better qualified to manage their problem. And then lastly, doctors are also responsible for filling out a lot of paperwork. So these are things like WCB, travel, fit for driving, and stuff like that. So like I said before, preventative health is a really big part of family medicine. In the chat box, type in what comes to mind when you think of preventative health. Like what kind of things are you specifically trying to prevent? What do you guys think? Strokes, yes. Diabetes. Heart attacks, cancer. Yes, fantastic. Those are great answers. So first off, like you guys said, preventing chronic diseases from developing. So for example, if an individual has a family history of type 2 diabetes and his diet's very heavy in refined sugars and he has a sedentary level of activity, he would be at risk of developing insulin-resistant diabetes. Luckily, diabetes is preventable. It can be prevented with lifestyle modification. So as a family doctor, you can counsel the patient on his risk factors and how to change his lifestyle. We also have addictions counseling. So lots of people smoke or drink more alcohol than they should. These are very risky activities in the long run. Chronic smoking causes COPD, hypercoagulability of the blood, and lung cancer. Chronic heavy alcoholism causes liver cirrhosis, and liver cirrhosis can cause all sorts of problems. Harm reduction counseling. So this is actually, I guess, relatively new in medicine. It's counseling basically on things that are safe sexual practices, not sharing needles with other people. And then lastly, screening really does fit into preventative health, but it's a pretty big area. So I decided to kind of talk about it in a separate section. Now, for potential data types, you can imagine there are actually quite a few. You can use demographics, so gender, age, occupation, where they're from, lifestyle, what do they eat in a day? Do they actually log their foods? Blood and urine results, epidemic data sorted by region. And we'll talk about that a little bit more in public health. And then lastly, this emerging new thing of genetic data. So here's one example of some preventative health stuff you could do. Sudden cardiac death is when a person dies because their heart stops working. So a lot of times people have risk factors that increase the likelihood of a cardiac event happening. But there are a lot of disturbing number of cases where young athletes would suddenly die because of some heart malfunction. One of the congenital causes that causes sudden cardiac death is in an otherwise healthy individual are channelopathies, where the ion conducting channels of the heart are defective. So this can potentially manifest as a long QT interval on the ECG. So here's an ECG. So this is the start of the Q wave, and then the T is measured at the end of the T wave. So, and this is called the QT interval. So the QRS complex, which is this whole complex here, represents the depolarization of the ventricles. And then the T wave, which is this bump right after the QRS, represents the repolarization of the ventricles. A delay between the depolarization and the repolarization can manifest as a long QT time. And just as a side note, the QT interval is affected by the heart rate. So you have to use the corrected QT interval in your assessment, also known as a QTC. So having a long QT interval puts a patient at risk of developing one of the polymorphic ventricular tachycardias. And this is what we see here. This is called the torsade de pointe. And this could turn out into full VFib, which is one of the ways people can die. It's a shockable rhythm. And you really want to try to avoid this from developing, because when they develop this, they develop VFib. And if it's not treated right away, they can die. So this is pretty interesting. This company called AliveCore developed this consumer-friendly ECG, an app that is able to recognize patients with concealed long QT syndrome. So they said they used a convolutional neural net to distinguish patients with long QT syndrome from normal patients. I won't go into too much detail of the study, but if you are interested, the link is right here in the slide. Another thing that happens is elderly fall. So the National Trauma Registry, and this is kind of old, in 2003, reported that in Canada, falls are the most common cause. They reported a number of 85% of injury-related hospital admissions among those aged 65 or older. So several studies show that people who have fallen once will likely to fall again in the future. In this vulnerable population, it's very important to respond quickly and recognize their mechanism of injury. So a study by Albert et al. Designed a tool that can detect the nature of a fall and alert a patient's caregiver immediately after the fall. To achieve this, a group applied 5 machine learning classifiers to a time series to detect the falls. And out of the 5, they found that support vector machines and regularized logistic regression were able to identify a fall with 98% accuracy and classify the type of fall with 99% accuracy. Study is here in the link if you're interested. Okay, so screening. Before we jump into it, I just wanted to do a mini lesson on sensitivity and specificity. Although a lot of AI papers focus on measures like accuracy, receiving operator characteristic curves or ROC curves, and the areas under curves, most clinicians tend to look at just sensitivity, specificity of a test when ordering it. So sensitivity is also called the true positive rate, or in machine learning, it's called the recall. And it's good at identifying those who have the disease. So a test with 100% sensitivity is able to correctly identify all patients who currently have a certain disease or condition. Specificity is called the true negative rate. It's good at identifying those who do not have the disease. So a test with 100% specificity will be able to correctly identify all patients who do not have a certain disease. So you might be thinking like, well, great, like I'll just use a test that's 100% sensitive and 100% specific. Unfortunately, a perfect test does not exist. Generally, in order to gain more sensitivity, you have to trade off some of the specificity. Likewise, to gain specificity, you have to trade off some sensitivity. So I'm a very visual learner, so I'm going to try to explain this with images. When I was first learning about sensitivity and specificity, I was taught with like these two bell curves, and to this day, I still don't understand what they're trying to show. So I personally prefer to visualize things this way. So let's say everyone that has the disease is this red dot. Okay, so patients with disease is in red. If they're labeled with a positive sign, it means that the test came back positive and they're correctly labeled as diseased. We call this patients true positives. If they come back with a negative result, it means that the test came back negative, but they were incorrectly labeled as normal. So they're still diseased, but the test told them that they're normal. So they're falsely negative. They're false negatives. So if a test is 100% sensitive, all diseased patients will get a positive test result, and they're all true positives. There are no false negatives here. If a test is 80% sensitive, all diseased 80% of the patients will get a positive result, but 20% will be falsely labeled as negative. So we're falsely labeling them as normal when they're really not normal. They really have the disease. So there's a false negative rate of 20%. And we can keep going here. So 50% sensitivity means that 50% of diseased patients are correctly labeled as diseased, and 50% are incorrectly labeled as normal. So the false negative rate here is 50%. Now let's move on to specificity. So this time, let's say green represents a normal patient. This patient does not have a disease. It's a normal patient. If they're labeled with a negative, it means that their test result came back as negative and they were correctly labeled as normal. They're considered true negatives. They truly are normal. If they have a positive sign, that means their test came back positive, but they were incorrectly labeled as diseased. So we know that these green people are normal. All of these are normal, but the test falsely classified them as being diseased. So these guys are considered false positives. If a test is 100% specific, all normal patients get a negative result. They're all true negatives. There are no false positives here. If a test is 80% specific, 80% of normal patients get a negative result, and 20% are falsely labeled as diseased. So there's a false positive rate of 20%. And here, a 50% specificity rate is 50% of normal individuals are labeled as normal, and 50% are falsely labeled as diseased. They get a false positive rate of 50%. So when we talk about sensitivity and specificity, it should always be together. So let's say we have a population of normal and diseased patients. And for the sake of this, let's say they're equal. So let's say we have 10 diseased in red and 10 normal in green. A perfect test is a test that's 100% sensitive and 100% specific. This means that all diseased patients will have a positive result, and all normal patients will have a negative result. No one is falsely labeled here. So let's say we have the same population, 10 diseased, 10 normal. Let's say this time our test is 100% sensitive and only 50% specific. This means all diseased patients in red will have a positive result. None of them are falsely labeled as negative. But 50% of the normal patients will be labeled as negative, while the other 50 will be incorrectly labeled as positive. So 50% of normal patients are incorrectly labeled as diseased, and we have a false positive rate of 50%. So same population, different tests. Let's say this time we have 50% sensitivity and 100% specificity. All normal patients here are correctly labeled as normal because our test is 100% specific. But only 50% of diseased patients are correctly labeled as diseased. The other 50% are incorrectly labeled as normal. They get an incorrect negative result. So this means 50% of the diseased patients are incorrectly labeled as normal, and the false negative rate is 50%. So I'll just leave this slide here if you want to do another understanding check after class. And I'll ask you a question here. So type your answer in the chat box. If you had to choose one, what would you choose? Would you rather have a test that's highly specific or highly sensitive? What do you guys think? Okay, it is a trick question. So it actually depends. It depends on what you're trying to do. Good, and someone did say it depends. That's great. So generally speaking, a test with high sensitivity is preferred for screening. If we have a good reason to believe that a patient has a certain disease or condition, this can be because of a clinical picture or a positive screening result, we'll use a highly specific test. So a test with high specificity is good for confirming. A test with high sensitivity is good for screening. Okay, end of mini session. So screening tests should be highly sensitive. That's like the ideal thing. If the result of a screening test is negative, we can rest assured that the patient does not have the condition we're suspicious of. A positive result, on the other hand, warrants further investigation with a confirmatory test. So why don't we do an example here? So let's say, we have a patient that comes in, you're an ER doctor, you're in ER right now. This lady named Patricia comes in, she's 43 years old, and she presents to the emergency room with a 2-day history of unilateral leg swelling, so one-sided leg swelling. Her right leg is hot, red, and painful. She had no trauma to that leg. She's on oral contraceptive pills, and she's currently smoking, and she has a 20-year pack history of smoking. You're suspicious of something called a deep vein thrombosis, or a DVT. So the screening test used for a DVT is a D-dimer. So this is a blood test that has over 95% sensitivity, but only about 50% specificity to DVTs. So with this in mind, the D-dimer test, 95% sensitive and 50% specific, your patient gets a positive D-dimer result. What do you tell your patient? So I'll give you guys about 30 seconds to think about this, and then I'll ask you to put your answer in the chat. Okay, so I'll just start timing now. Okay, if you haven't typed your answer in, type it in. Okay, nice. You guys are good. And yes, that's right. The answer is C. You'll tell her that we're not sure if you have a DVT, but based on these results, we should further investigate for a DVT by doing an ultrasound of your leg. So in this scenario, it's actually pretty close to this picture. We're suspicious of a DVT. So we did the screening test, and Patricia's test came back as positive. Our test is almost 100% sensitive, but only 50% specific. So this means her positive test, she could be in this group where she's a true positive, or she can be in this group here where she's a false positive. And the only way to find out if she actually has the DVT is to do a confirmatory test. This slide is just to show that two tests one being very sensitive and the other being very specific can be very powerful when used together. So I'll just leave this here for you to look at later. Okay, so screening. In terms of screening in a primary care setting, so let's say in a family doctor's office, in the chat, type in what comes to mind when you're screening. What exactly are you screening for? Genetic abnormalities. Okay, that's a pretty good one. Any other ideas? Okay, so in the doctor's office, cancer screening is a really big one. Yes, signs of cancer, good. So colorectal cancer screening after the age of 50 is recommended for everyone every single year. Breast cancer screening is also recommended for all women after the age of 50 every 1 to 2 years. Cervical cancer screening is recommended for every woman after the age of 25 or when sexually active, whichever one comes later, every 3 years. And mammograms, yes, breast cancer screening is done with mammograms. So these three things are specific to North America. There are different parts of the world. I believe Japan also screens for stomach cancer because their population has a high rate of stomach cancers. Another thing you can screen for are STIs. So anyone who has kind of like risky behavior or anyone who basically wants an STI screen can be screened for it. And STIs, sexually transmitted infections. Other common conditions are actually routinely screened for in the office. These are things like diabetes, you'll measure an A1C, hyperlipidemia, you can do a cholesterol panel and lipid panel, and all these other things like osteoporosis with bone mineral density and anemia with hemoglobin. And this is a newer initiative, but actually screening for psychiatric conditions like depression and anxiety in high-risk individuals. So potential data types are things like demographics, as usual, the screening results, so the mammogram results, the FIT test results, epidemic data sorted by region. So if you live in a place that has a lot of heart attacks, you should probably look for signs that could put you at risk for a heart attack, like hyperlipidemia. And then genetic data is a newer part of this, still kind of emerging. So here's an example of how AI can be used for screening. A paper by McKinney in 2020 developed an international evaluation of an AI system for breast cancer screening. They compared the current UK system of breast cancer screening, which requires 2 radiologist reads, with their AI system. And then they compared the US system of breast cancer screening, which requires only 1 radiologist to read, with their AI. And they got some pretty interesting results. So I won't talk about the details of this too closely, but the link to the paper is in the slide here. In 2019, this research group presented a step towards automated image evaluation via lung cancer risk malignancy estimation through deep learning. So they found that the model achieved significantly better specificity than the average radiologist. Again, link in slide if you're interested. And then, of course, one of the obvious responsibilities from a primary care provider is to diagnose a patient with something when they come in with a complaint. So since family doctors are generalists, they're responsible for diagnosing pretty much anything related to any organ system. And then some potential data types would be blood and urine results, images, and then just imaging investigation results like X-rays, CTs, MRI, and ultrasound data. In 2017, this research group used a deep convoluted neural network that was able to classify different skin cancers. And I'm just going to read a quote. They say the first case represents the identification of the most common cancers, and the second represents the identification of the deadliest skin cancer. The convoluted neural net achieved performance on par with all tested experts across both tasks, demonstrating an artificial intelligence capable of classifying skin cancers with a level of competence comparable to dermatologists. And link in slide if you're interested in learning more. In August 2020, so this is actually pretty recent, this group, Harmon et al., use deep learning to detect COVID-19 associated pneumonia in CT chest CTs. So they reported an 84% sensitivity and 93% specificity for this tool. And again, link is in here in the slide. So virtual medicine has recently exploded with the recent social distancing requirements, and it's becoming a really big part of primary care. And virtual medicine is basically anything that doesn't require in-person, face-to-face contact. So that could be over the phone or through video chat. Smart tools that use AI are starting to become better recognized in the field of primary care, especially in virtual medicine, because these tools can allow patients to record their own data in the comforts of their own home, and they can also alert them on new patterns. They can get medical advice from them, and they can access physicians quicker this way. So here's one example. So generally when a physician wants to order an ECG, the patient's given a rec, so a lab rec, to go to the local diagnostic lab. Some clinics have their own 6-lead ECG for a quick on-the-spot look at the heart, but usually they'll do that in the clinic, they'll get kind of like a rudimentary result, but then they go do like the real test in the diagnostic lab. So we already kind of talked about AliveCore, but in addition to diagnosing long QT syndrome, this is a consumer-friendly device that can help patients get a 6-lead ECG reading at home. So this kind of replaces like the on-the-spot in-clinic ECG that some healthcare practitioners do. And recently, Babylon and TELUS Health developed a Canada-specific AI app that scans a patient's survey answers, then connects them to a video with an appropriate healthcare provider. So this app kind of acts like a mini triage system, and it also connects them directly to a physician that they can connect with remotely. They have a bunch of research, and I put a link to their research pages here. So public health, this is our second last topic. It's a really big field, and unfortunately, I won't be spending too much time about it, talking about it. But basically, public health deals with anything at the population level. So it's more just than controlling infectious diseases. A lot of times, especially with COVID, now we think of people who work in public health are people who track all these viruses and infectious diseases, but they're actually responsible for all kinds of issues that are epidemics, but not necessarily infectious disease epidemics. These are things like opioid crises, obesity epidemics, just like availability and accessibility to healthcare. Those are all public health initiatives. So I thought this was an interesting paper. Metabolic syndrome, I'll just quickly define it, I guess. So metabolic syndrome is a cluster of conditions that occur together that increase your risk of heart disease, stroke, and type 2 diabetes. So these things are like if you have increased blood sugar, high blood pressure, excess body fat around the waist specifically, high low density cholesterol, or high triglyceride levels. A lot of people who have metabolic syndrome are also obese. So when you see like an obese person, like they usually also have metabolic syndrome. But there are a lot of people who have metabolic syndrome who are not obese. So in 2018, this Korean group developed a prediction model for metabolic syndrome in non-obese people using both clinical and genetic information. So they used clinical and genetic polymorphism information with 5 machine learning algorithms, including naive Bayes classification. And their goal in this study was to help identify non-obese metabolic syndrome individuals and kind of guide them towards getting more health checks and adopting preventative lifestyle measures. Link is here if you're interested in reading more about it. Canada has its own AI initiative against COVID-19 outbreak with a task force led by CIFAR, Mila, Vector Institute, and the Alberta Machine Intelligence Institute. So the Canadian Institute for Advanced Research, or CIFAR, I'm not sure, are leading projects that involve machine learning and support public health measures. So they're doing a lot of at-risk stuff, which is a public health measure. And then last topic for today are health apps. So health apps are becoming increasingly popular. They're really good for tracking your own health. Like if you're interested in seeing what kind of trends you do or what kind of things, what kind of patterns you have that you wouldn't otherwise see normally, you can use a health app. They also allow physicians to track their patients' health. So if you have all this data that you can upload to the physician, they can actually look at it. The last thing that a lot of people don't think about is that companies can also collect your own data when you're using the app. So a lot of companies that do collect the data, they'll usually make you like checkbox something that says, yeah, I understand that my data is being collected. When they collect your data, they can use it for their own research and they can also sell it. So it's also a really big thing for companies to develop apps so that they can collect data that way passively. And I'll go back to just this, where does health data come from? Devices is becoming a really big one. A lot of health data is starting to come from personal devices. So here's an example of a health app that uses AI. It's called Migraine Buddy. So this group uses deep analytics and machine learning. I couldn't find too much information on this. I think they're being secretive. But they allow users to easily track aspects of their migraine attacks, including triggers, symptoms, medication, and pain intensity. And this is kind of like what it looks like, and it can kind of identify some possible triggers of your migraine. But here's kind of a paper. It was more of like an article on it. Medtronic developed an app that allows insulin-dependent diabetic patients to monitor their blood glucose automatically and log their food. So they use machine learning to find patterns of hyper and hypoglycemia and integrated an automatic insulin administrator based on their blood glucose measurements. So their data can be accessed by themselves and also accessed by their healthcare provider. And Medtronic, the reason they were able to even develop this in the first place is because they had like this blood glucose slash food logging thing, and that's how they first developed it. They collected all of this data, they trained all of their machine learning stuff, and then they were able to actually make this automatic insulin delivery system. So pretty interesting how they decided to collect their data. This one is interesting. So this group used image recognition to track basically schizophrenic patients taking their med to ensure that they're being compliant with their meds. I can imagine some limitations to monitoring patients this way in terms of their compliance, but I still think it's interesting. Link is here in the slide if you're interested. This is kind of hard to see. I know, kind of blurry. But these are like the companies that exist today that use AI in healthcare. And I'll leave this in the slides for you to look at. Some of them are pretty interesting, but I thought like, oh, AI in healthcare is so new, but like there are all these companies that are like already using it. So it's really an exploding field. So this is a nice summary page. I won't go through everything, but this is what we talked about today. We talked about health data and the types of health data, primary care and the responsibilities of a primary care provider, as well as some examples of how AI is being used in primary care. A little bit of public health and a little bit of health apps here at the end. And that's the end of my presentation. Thank you so much for listening. I'm happy to take any questions through the chat right now, or you can contact me via email. I'm happy to answer. Thank you.
There's one question in the chat there.
Oh, okay. Let's see. Let me open it. Okay. So it seems to me that more longitudinal data, the more longitudinal data is better. Is that your assumption too? Actually, Khaled, can I talk to you? I'm not sure I understand your question fully.
I think he means that the more long-term accumulation of data you have, better predictions you can make.
Okay. I think it really depends on the application. Let me go back to one of these guys, one of these slides. So I think this is an example of something that you don't need longitudinal data. This is like a spot diagnosis. You don't really need to see what it looks like before or after. The whole point of this AI is to not have any information for before or after. So your model would only be based off a spot diagnosis. So I guess my answer to your question is it depends. It depends on your application.
So I can add that if you're looking at development of chronic diseases and how the lifestyle factors affect what kind of disease you might develop, then in that case, it's the whole story of your health that leads up to that disease later in life. So in that case, longitudinal data is essential.
Okay, and there's another question here. Thank you, Shane. So Atisha, I hope I pronounced your name right. What factors can cause a disease that can spread across the community? So there are some things like infectious diseases, for example, like the human papilloma virus. That's an infectious disease that can cause cervical cancer. So there's kind of that way of looking at it. But then in terms of like a disease like let's say obesity, um, oftentimes a lot of people who are obese are often associated with lower SES status. So people who don't have access to gyms or like healthy foods, like they just have a lot of fast foods around them that are cheaper than healthy foods a lot of times. That's like on a population level, kind of like a disease that looks like it's being spread in a certain community, but it's not actually being transmitted. It's just like the situation that they're in that causes them to have this disease. Hopefully that answers your question. And thank you, Sarah, for your answer on longitudinal data.
There's a long question here.
Yes. And I think there's a question right before. So Wenhui, the AI learned based on sensitivity and specificity, am I right? So there are different ways to kind of assess how well an AI functions. So Shane has a talk in March all about evaluating how well an AI performs. But sensitivity and specificity is a really big part of assessing the performance. They're just expressed in different ways, primarily through ROCs and area under the curve. Okay, and then I see this long one. With health apps right now, is it fair to say that it may be relatively biased since only certain pieces of info are being looked at? But also when it raises the question of one, are the companies, largely in the state, because well, their business-oriented system, using this to drive healthcare decision making for the future? And two, are discussions being had in terms of creating a framework to facilitate better data collection from apps to have more accurate data sets? I'm going to think about this. Shane, do you have an answer to this question?
Yeah, so pretty much all the data has anything that's not very carefully planned out and collected with very strict criteria about eliminating bias, any data will be biased. And especially with companies, they have a target market that they're aiming for, and so you get data that's biased to that target market, and it and if you do any kind of machine learning on that data, it'll only apply well accurately to that demographic. And is it being used to drive healthcare decision making for the future? So that is uncertain at this point. There's like companies are collecting a lot of valuable data that healthcare would love to have access to. There's a lot of privacy concerns, and for the companies, they're the owners of that data, even though it's your data, because you've signed off the checkbox that they can take your data and do what you want with it. So there has to be a discussion about maybe even a partnership between healthcare and companies to figure out what the best way is to take advantage of all this data that's being collected. But as far as I know, there isn't anything like that currently. And yeah, is there a discussion? Are there discussions being had? I hope so. I don't know of any off the top of my head. But yeah, in an ideal future, then healthcare will be defining what kind of data collection companies can collect, rather than the companies choosing it themselves.
Yes, another question I also have is, I mean, I would like to think that Canada is relatively different than the States. But in Canada, maybe is there something like maybe with Health Canada, is there something or some agency dedicated towards like looking at how that data is handled, either from like the governmental side or from, I don't know, just I feel like this is like a huge concern in the future or like the near future that's not really being taken seriously. And
Mm-hmm.
that's what I'm curious about is like how can that step be taken, or where would someone go to even start taking those steps?
Yeah, well, the starting point, at least here in Alberta, be to go to Alberta Health Services and have them. They're in talks with the government, Ministry of Health. They'd have to initiate a discussion about AI and how data can be used to improve the healthcare of Albertans and then Canadians. And I think part of the reason why we don't hear a lot about of it yet is because not a lot of people are really aware of AI and what it can do in healthcare, and what kind of how big an impact it's going to have, and how valuable all this data is. But yeah, it's really not clear what the path forward is at this point. And like part of our like our club here, AI in Medicine Student Society, the point of that is to raise awareness of AI and how it can be used in medicine and get the discussion going. And we're trying to incorporate that into medical education and get people thinking about it. I think it's very much a work in progress, and there really is no clear answer at this point.
Kind of unsettling. Like, yeah, no one's regulating it. It's just being sold.
Well, yeah, especially because like how rapidly technology does advance compared to let's say policies. It's like I didn't know if there was something happening at like a national level, for example, to like already start creating some kind of framework for this, because that's some yeah, I guess there isn't from what you said as
At
well. There's
least not
just
that I'm aware of.
okay. I mean, that's probably a better answer than I can find. So
Yeah, I think they just usually cover themselves legally by making you kind of sign a thing that says you can't use our health app unless you sign our terms and conditions. And then the terms or conditions in the fine print is like, we're going to use your data and it's ours now. And as far as that goes, like they are legally covered. Like you can't really fight that. But yeah, it is unsettling.
Yeah, contact your local government and tell them to raise the issue.
No
I
kidding.
would like, I mean, I wouldn't imagine they knew what AI was, to be honest
Mm.
with you. But
Yeah,
one step at a
Yeah.
time. I don't want to pull a boomer joke, so I'll just stop talking here again.
Oh, and I think we have a new question. What are some of the expectations of these health apps could have in the future? That's a great question. Yeah, I think like apps are just such a big part of our lives right now. Like I have an app for pretty much everything. And especially with virtual medicine becoming more accepted, um, like a lot of people are just going to rely on apps to kind of keep track of their health, gather more data on their health, and just check stuff through that. One of them being just like that diabetes uh, application I was talking about. Shane, do you have anything to add to that?
well, it depends on how far in the future you want to imagine, but like I think near future, for example, your smartphone, it's collecting it has an accelerometer detecting all your motions, how much you walk, what kind of motions you use, and depending on the direction, it can figure out uh, what what you're, not just how much you're moving, but what kinds of motions you're doing, and that could be fed into your daily health checkup and feed into your family doctor, and they can say, oh, you've been moving this much. It can go right into a risk calculator for this disease or that disease. And similarly, what other apps are there? There's like a smartwatch will take your pulse, your heart rate, and can feed in your heart rate. It can detect whether you have any slight abnormality. It might not be able to diagnose you with something, but it could say, oh, your movements have changed recently, your heart rate is a little irregular, and I'm detecting some sweating on your wrist. Maybe you should go see your doctor and have this checked. So I think the major application would be preventative health, collecting as much data as possible and catching the subtlest patterns emerging and stopping disease before it develops.
That's a great answer. In the far future, we'll all be virtual and our entire lives will be on apps.
We will be apps in the simulation,
We are apps.
in the matrix. So I don't see any more questions. All right. Well, thank you, Amira, for the talk, and hope everybody learned something. And next week is no workshop next week. That'll be in 2 weeks, and then our stream A part 2 is next weekend. And look out for the announcement for the symposium, and make sure you sign up. It's going to be really interesting, and you might get some Ames t-shirts out of it.
Nice, awesome. Thank you so much, Shane, for hosting this. And thank you everyone for attending this.